talk. The platinum sponsor, the company is EasyWell. I would like to invite, and sorry for butchering the name if I may say, David Azunu. He's a research and development manager in infant nutrition at St. Mary. He'll be talking about advanced technology in infant nutrition.
Assalamu alaikum. Masā al-khair. I know it's maybe many people are not here yet, but because of the time and our schedule should not be that late, we'll give 20 minutes for our main sponsor, the platinum sponsor. They are having a small, presentation for you, and I wish it will not last more than 15 minutes. So are they here, the Aizuba? Aizilak, where you are? Do I see you? Yalla, come. Please, go ahead. People, just after lunch, post-brandle, you need to really make them awake. I think they have some surprises for you to keep you awake and reward you because you come early, after lunch. Go ahead, Dil.
Hello, I'm very glad to be with you today. And it's an honor to present you some innovations in technologies in infant nutrition. Okay, I take part of cooperatives in Saint-Mère that you see here in Normandy, in France. Donc a piece of history to show you a bit our big experience on 66 years, approximately. Donc we began the creation of a cooperative at the beginning of the 20th century, as you can see. And the first baby milk powder production in Normandy and France was done at Isigny in 1959. After we extended some capacities with new drying towers. I will show you right after the process, manufacturing process. And we added also a laboratory, a powder testing laboratory, to be able to test as much as we can internally all our finished products. Donc, as you know, we are in the middle of a magnificent territory, Normandy. Donc, a bit different than Saudi. Donc, it's a big giant swamp. As you can see, we are in the middle of a giant swamp between land and sea, with that brings you exceptionally rich grass growth and helps the cows to have this perfect nutrition. Donc our gold at Isigny is not oil, as here, or something else. It's our milk. Donc it's collected around the cooperative, around the factory, approximately maximum 50 kilometers around the factory. Our farmers are our boss, in fact, because we are a cooperative, we are a dairy cooperative, not a private group. And we produce really locally, and we use fresh milk, because we'll collect every 48 hours on each farm, and it arrives fresh at the cooperative. Talk about some technologies. Wanted to present you something that you don't know very well as neonatologists or pediatricians. Three main advanced technologies in infant nutrition. Our first, general consideration about full wet blending process of manufacturing. And after two very interesting and sensitive ingredients, DHA and iron, that we protect through encapsulation. First, we collect the milk, you understood that, and we bring to a cooperative. We will, of course, analyze and pasteurize to make it fully clean in liquid phase. We will after mix lots of ingredients with the milk, depending on the formula. Now we have over 1,500 different possibilities of ingredients. We'll pasteurize again this mix, liquid mix, and homogenize to have a perfect quality. And we will follow at each step with auto controls the composition, the criteria, the physicochemistry, physicochemical criteria, and others, and sensory also. We'll concentrate on mixed concentration to be able to remove some water before going to the big drying towers. And after, we will proceed on a big drying tower that you see on the screen to evaporate the remaining water and to produce powder. Through all of that steps, we'll continue to analyze, to check the conformity of everything, composition, density, for example, scoop weights, etc. And we will finally go into packing steps when we are ready, before getting to palletization. And the release will be done on all the traceability elements, results that you have along the process, and also some auto controls, as I said, and critical control points that you know. And after, also on the release on the laboratory analysis that we have internally and sometimes externally, to release the batch on all of its results. So the main thing to retain on this drawing is we are working as much as we can on the full wet blending process in liquid phase to have something very homogeneous, to guarantee the food safety and to respect and to protect the nutritional part, nutritional quality. And as you see also, we are preserving the freshness of the milk, because between the collection and the arrival at the cooperative of the milk and the finished products, we have maximum 72 hours, which is quite very short time, and make a good preservation on the quality of milk. Some pictures, quickly, wanted to pass it through because it's quite interesting on the process that you don't see every day. Look, you see many different things, different parts, different equipments. For example, pasteurizer on the left, on the bottom. And you see lots of controls on quality, we'll come back on it, on environment, on equipment. As you can imagine, it's like in your surgical operations room. We use approximately the same rules to ensure perfect food safety for babies, including premature babies, for example. And lots of things to permit to go, to be reactive and to go quickly from the milk to the finished products. For example, the silos of powders that you are seeing on one of the pictures. And as I told you, all the auto controls, you see a bit of powders testing by composition at one part to be sure that at each step we have a perfect quality. We can add something else because we are working in a liquid phase, 100%, and we can add some additional options to protect sensitive ingredients, as I told you, particularly DHA or iron, for example. And for DHA, you know that DHA is one of the main polyunsaturated fatty acids with long chain found in breast milk. It's not present in cow's milk, and the amount of DHA is very different from one woman to another, depending on diet, nutritional status, and other factors. And in breast milk, the average concentration of DHA seems to be close to 0.32% of total fatty acids, as we saw in this study in 2019. And in human body, you know that it's accumulating in the brain, in the retina, during pregnancy and early childhood. Your colleague Kolecko from ETSGAN told us that in 2008, as we knew, as we imagined before. And it takes part more specifically on the we can say the brain for 40% and on the retina tissues for 60%. But however, the rate of conversion from alpha-linoleic acid that you know very well to DHA in humans is low, less than 1%, as we saw in some reports, for example, from EFSA in 2006. Donc, DHA synthesis is limited in infants, donc therefore it must be obtained from infant nutrition. And also, as you can imagine, it's the longest polyunsaturated fatty acid, DHA, donc very sensitive to oxidation. Donc it can bring strong fishy smell and flavor, You had this experience by the past, I imagine, and it can be nutritionally denaturated, which is not so good for all of us. Donc, where technology can help to protect these very sensitive fatty acids. Donc, a bit of process. Donc, we will mix all the lipids and the other ingredients, protective ingredients I will show you in the liquid phase to make an emulsion in the first hopper and the first tank. And after we will spray dry, as we do on MSD, multi-stage dryer for finished products. We'll spray this liquid inside a very dry and hot air to be able to evaporate the remaining water. And after we'll obtain a powder that we will be able to use in our process in the liquid phase. Donc it's a bit like that. You will see some drawing. Donc first step is to aggregate, we can say, and protect, to have a single shell protection of a lipid globule in emulsion. And after we will re-encapsulate second time to have a double shell protection and cross-linking to be resistant to a process. And as I said, spray drying to obtain powders. Donc this is the composition. It's 60% of refined fish oil rich in DHA inside in yellow color. And all the other ingredients, fish gelatin and lots of antioxidants, as you can see, sodium ascorbate, tocopherol, ascorbipalmitate, for example. They are used to help to protect the ingredients and also during all the shelf life of these ingredients. Donc it's the reason why we add this encapsulated DHA to our EasyLac formula. Second very sensitive ingredients that you know very well also, iron. Donc as you know, iron is linked to numerous drawbacks when you put inside some infant baby milk powders, because you can have sensory problems with metallic taste. You can have technological problems, oxidation of fats and vitamins during the process, but also during the shelf life. And nutritional problems because you can have poor bioavailability by binding to other ingredients, to other elements. Donc we use a micro-encapsulated and micronized source of iron to prevent from these problems. Donc you don't feel metallic taste in this case because this micro-encapsulation technology avoid the direct contact from free iron to you. And no oxidation also on fats and vitamins because it will protect against the interaction between free iron and the other ingredients, sensitive ingredients as DHA, as we said, for example, other fats and some vitamins, as you know, linked to vitamin C and other vitamins. So it will limit the oxidative capacity of free iron by protecting the interaction. And for us, it's easy to use because it's water dispersible powder with approximately 8% of elemental iron, which is sufficient to be able to adjust the formulation and to have the right amount of iron that we need. Now we can use these ingredients in various different conditions. Just to show you on this slide that it's possible to use on a very high temperature product, higher temperature process, like pasteurized and UHT milk, evaporated milk, and of course, as we are telling today, spray-dried milk and infant milk. Donc you know, as experts in medical parts, that iron is very important, and iron deficiency can affect some systems, like immune system, for example. Alors, just to remember, the immune system is impaired by iron deficiency because of the leukocytes. They will have a reduced capacity to kill ingested microorganisms, and the B lymphocytes have a decreased ability to replicate when stimulated by pathogens. Donc we saw that in some different studies. Donc it's very important, and WHO also demonstrated by the past the relationship between iron deficiency and impaired immune system. The same impact is also quite important also on cognitive development between anemia and only deficiency. Donc for infants suffering from anemia, it's very clear that we have some great deficit in IQ compared to their classmates. Some old studies showed that. And also, in case of deficiency, as you see on the second paragraph, you are able to come back to normal, but it's very difficult because, as you know, iron, it will take time to come back to normal by enriching the food. It's very, and the damages are sometimes not reversible. It's very important to keep an eye on it. And just to show you, to finish, efficiency study that was done with this ingredient on young women, because it takes part also on pediatrics, young women. Look, we saw that it was very efficient in terms of enrichment and supplementation with, compared to the reference group without. It was made on juices with iron supplementation or not, and it's quite efficient, as you can see in red, after a few weeks of use. That's the reason why we add encapsulated iron like that in our formula, to avoid all of these drawbacks. In order to finish, the last slide about the food safety, very important for you, but particularly also for us. We have a brand new laboratory with more than 100 persons, and they are performing more than 250 different controls on each batch produced to be sure that we can release without any problem. And every year it's approximately 1 million quality tests done, and we have more than 100 people assigned to product quality, approximately 14% of our total head count. For us, it's very critical, and it's the main purpose before releasing all the products to Saudi. Thank you very much.
Thank you.
Thank you.
Thank you, Dr. David. Thank you for our main sponsor. It was in-depth information. Now we'll fund a factory. We will do a factory to compete with your company. Yes. Thank you. But we need cows. Yes, we need cows. Okay. Then, with no delay, we will start our next session. I will invite the moderator, Dr. Isa, and Dr. Najla, to start. Dr. Najla Abdulaziz or Dr. Isa, they will lead the session. Go ahead. توكلوا على الله.
Okay, many thanks to the organizing committee for inviting us. And it's a pleasure to be here with you all today. During this session, we will have 3 speakers. And with me and the moderator, Dr. Isa Sultan, consultant neonatologist at National Guard Hospital, Medina. We will start with the first speaker, Dr. Fahd Al-Aqil, who will be speaking on defining the edge of viability. Dr. Fahd is a senior consultant neonatologist at Care Medical Hospital. He completed Canadian fellowships in neonatal perinatal medicine and neonatal follow-up at the University of British Columbia. Dr. Al-Aqil has made major contributions to newborn care in Saudi Arabia. And please join me in welcoming Dr. Fahd.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much for the moderator, and thank you for the organizing committee for inviting me for this prestigious meeting. I will talk today about the age of viability, the ethical and clinical perspective. Yes. Okay, so I'm working on Care Hospital, which is the first hospital, a private hospital, started in Saudi Arabia around 60 years ago. And we have a small unit, but we are level 4, taking care of open heart surgery in units. And this is the first private hospital accepting open heart surgery in the neonatal ICU. So starting with the definition, of course, the challenge is when you are resuscitating or have a call to resuscitate a baby between 22 to 26 weeks of age, of gestational age, because there is a clinical and ethical and legal consideration, and this is not an easy. So what is the definition of age of viability? Of course, it is not an easy, because the question has been extensively discussed politically, legally, religious, philosophically, and scientific conversations to define the age of viability and what the meaning of viable babies. A single universal definition of the limit of viability cannot exist, because each baby is different, each setting is different, and each community also is different. So you cannot implement a definition which is from another country or another community, or even sometime from another unit. The almost 200 years ago, William Potts, who's the American obstetrician, defined the viability as the capacity to sustain life rather than the mere sign of this condition, which is very nice theoretical definition for the viability. But now, what is the definition we should use to define the age of viability? Is it survival to discharge, which is approaching or exceeding 50%? This is a definition which was taken by the North American, and although it is not clear what is the why 50% and survival to what? To go home, to pass neonatal period, to have the 1 year of age is not clear. In the UK, the definition was more clear, which is still not that clear. Gestational age where 50% survive with the modern intensive care unit. In the World Association of Perinatal Medicine, they define the age of viability as the age when sufficiently mature to survive, for the neonate to survive the neonatal period, which is 28 days. So if 50% of the babies will pass the 28 days, then this is the age of viability. So it is changing, 50% chance of surviving. So we are dealing with unclear definition to start with. And because of this, we are changing every time. In the 60s, we are doubting the 30 and 31 weeker. And on the 80s, we start resuscitating or talking about 26 and 27 weeker. Shall we resuscitate or not? In 2000, 24 weekers, and now we are talking about the 22 weeker. So it is changing with the time. 40 years ago, we are resuscitating the 34 weeker, and we are sure they will survive. Now we are talking about a 22 weeker. Shall we resuscitate or not? So why we need a clear definition? It is not only for the physicians. It is also for the parents, for the general population, the people, the parents, for the religious scholars, for the decision makers, and for the court. We need national clear definition for the age of viability. So until more accurate model of a neonatal prognostic are developed, gestational age remain the primary but not the only. And this is a very important point, not the only predictor for the guidance for the time or age of viability. So we still depend on the gestational age as the main and the most important factor. If we are depending on the gestational age, then we have to divide the babies to 3 groups. The too small or too immature babies who are usually, if you are talking about 20 weeks of gestational, have not survived as per the published or literatures. and few babies survived at 22 weeks, so they are too small to be resuscitated, and almost everybody agreed at this time that this age should not be resuscitated or offered the comfort care. On the other side, the too big babies and too mature, when we are talking about 24-weeker, in the high-income countries, in the good intensive care units, then there is a good survival rate, and everybody again agreed that this is, should be resuscitated, and we left it with the gray zone, which is the 22 and 23-weeker. So if you wanted to do a national level, deciding the age of viability, what are the challenges? Of course, there is challenges related to the maternal and antenatal system or care system in your country. You have to study the antenatal referral system and the maturity of the maternal system, the labor and delivery and neonatal care leveling, and the capacity of the labor and delivery and the neonatal and the networking between the NICUs. Neonatal transport system availability is a very important factor to decide about the age of viability. Not only the availability of neonatal transport, but the capacity and the quality transport. The post-discharge medical and non-medical support for the baby, and the same thing, the support financially and non-financial support for the family.
صارت في الفيديو
So
صح؟
what is the impact of putting a national definition for the age of viability? There is a medical, ethical, and emotional complexity. The ethical and legal dilemma, are we helping this baby or increasing the suffering of the baby and his family? The other thing is the undesired burden on the infant during and after the NICU, and the undesired burden on the health system during and after the NICU admission, and the undesired burden on the family during and after the NICU admission. If we will go through some of the international experience, most of the time we will remember Japan, and we will remember that Japan changed their age of viability definition from 24 to 22 weeks since 1991. And most of us, they will not know that even in Japan, not every infant born at 22 or 23 weeks will be resuscitated. Actually, in a study done in 2024, there was almost approximately 14% of those babies born at 22 weeks, and almost 2% of babies born at 23 weeks were not offered any resuscitation on the labor and delivery, and this is a decision was made in the labor and delivery. So it is not, although they have a clear definition of the age of viability, it is not mandatory, and still they will individualize the decision in 22 and 23 weeks. What about the United States? The American Academy of Pediatrics recommends an individualizing the approach between 22 and 24 weeks, and there was this was since 2015, and there was last year a nice paper, a commentary paper published by an international group of neonatologists, ethicists, and parents advocate. Very nice paper talking about the decision of resuscitating less than 24 weeks. And the summary of this paper is we have to be clear with the parents about the outcome of this gestational age if we decide to resuscitate. And routine resuscitation of less than 24 weeks is not in the best interest of all infants, so we have to individualize the decision. We must address the methodology limitation of the neonatal literature talking about the outcome of premature babies, because sometimes they are grouping all the less than 26 or 28 weeker together and mislead the decision maker. And if you decide to resuscitate 22 or 23 weeks or even 24 weeks, you have to be ready for the investment on the long-term follow-up care and supporting the baby and the family. What about UK? UK in 2019 published their recommendation, which mentioned that you have to consider resuscitating 22 weeks, and you have to assess the risk and decide based on the risks. But based on this recommendation, most of the doctors start resuscitating every 22 weeks. So they make a clarification on the decision, which was published only 2 weeks ago, and it is now on the website, which they did very nice thing, which they divided the groups of 22, 23, and 24 weeks to classify them into extremely high risk, and moderate risk group. And they recommend comfort care for the extremely high risk infants and survival focused care for the moderate risk group. So they are trying to avoid the unclear resuscitating of every 22 or 23 weeks. To summarize, most of the high-income countries' recommendations and the countries or societies or association, I put them in, most of them in this table. And as we can see, most of them will not recommend active resuscitation before 24 weeks. And either they comfort care 22 and 23 weeks, or there is no clear recommendation, or sometime no active individualizing the care for this group of age. So what about Saudi Arabia? Now, before talking about the medical side, we have to talk about the Islamic scholars' decision in Saudi Arabia. This is the famous fatwa that we are following in the neonatal ICU, and it was mentioned clearly that if the baby born after 6 months of pregnancy, then you have to offer what is the maximum support if it is available. And if they mention here the word wajaba. And wajaba, sometimes we are not understanding it nicely. In the Islamic meaning of wajaba is you have to, it is a must. In another way, it is prohibited not to do. So the word wajaba is, for me, need more clarification from the Islamic scholar if we have to mandate resuscitating of all those babies or not. The others, the remaining part of this fatwa is if the baby is less than 6 months then, of pregnancy, then 2 doctors will decide about the decision for the resuscitation. Now, in the there is a papers in the from the scholars published also. This is a very nice paper from Dr. Salih Al-Ghlaiga from the Imam University, and another paper from Dr. Asma Rashid also from Imam University. A nice paper from Dr. Hela Liabis in the Imam University also. This is part of it. Maybe clarifying what is the more than 6 months of pregnancy and what is less than 6 months. And it was clear from the scholars that sometimes we are misunderstanding what is 6 months. 6 months, according to them, is 27 plus 2 days, not as we are thinking 24 weeks. So we have to revise this again. And then it maybe help us that if it is 27 plus 2, then it is mandatory and prohibited not to resuscitate. In 2014, we published our definitions, our national definitions, and those definitions were distributed, signed by the Vice Minister, and distributed to all the hospitals. I will not go. Actually, it was distributed to MOH hospitals and also through the Saudi Council distributed to the non-MOH hospitals. And I will not go through the definitions, but we have the perinatal period, abortion definition, neonatal death definition, stillbirth definition, and this is the most important policy, which is the age of viability and resuscitation policy. So to summarize this policy, if the baby or the fetus born less than 16 weeks, you have to send the product to the pathology. You don't need to have birth or death certificate, and you don't need to register this product in the neonatal statistics. But if the baby is 16 to 21 weeks, then you have to send the product to the morgue. Again, no need for certificate or registration on the neonatal statistics. If the baby is, or the product is 22 and up to 23 weeks, and there is sign of life, then you have to register this product to the neonatal statistics, but we are not recommending resuscitation. If the baby is more than 24 weeks or 24 weeks and more, then you have to issue a birth certificate, and in case of death, a death certificate. You have to register the baby in the neonatal statistic, and you have to resuscitate. We also recommend considering the transfer at 22 up to 30 weeks, transfer the mother to a tertiary center. And if the gestational age is not clear or not established, then you have to resuscitate based on the weight, which is 500 grams at birth. So despite the policy, still the resuscitation of age of viability is a challenge. There is a study which was done, survey done in 2014, requesting an answer from a neonatologist about the age resuscitation of 22 up to 24 weeks. And the conclusion was there was a strong recommendation for comfort care at 22 weeks and for resuscitation at 24 weeks, with the individualizing 23 weeks. Of course, there is a cultural, social, and legal consideration when you are deciding about the resuscitation. We distribute, actually I did a survey, which was, we collect the reply, but we did not publish the paper yet. So I will present some unpublished data, which is from a survey which distributed to all the nationally to all the NICU staff. We asked them about 5 clinical scenarios. What you will do in case of 22 weeks non-fibrous male, 22 weeks fibrous female with antenatal steroid given, 23 weeks non-fibrous male, 23 weeks fibrous female with antenatal steroid given, and 24 weeks regardless of the age, or regardless of the sex or steroid. And actually, I received the reply from more than 1,000 reply, most of them from Ministry of Health. Of course, we are sending it to all the NICU staff. And this is national, only in Saudi Arabia. So anyone who is outside Saudi Arabia excluded from the study. And we ask the question, I will not present the whole things, but the most important things, we ask who's making the decision if you are dealing with 22 to 23 weeks. And most of the answers said the neonatologist. So based on this, we decided to go to the neonatologist. There was in the reply from 194 neonatologists, and they are from different areas in Saudi Arabia. We asked them the same question, who is deciding? And 90% said neonatologist is the one deciding about the resuscitation. Okay, so the decision, most of the neonatologists, actually 175 replied that they will offer comfort care to at 22 weeks. Some of them will give full resuscitation. If in a male who is not fibrous and no antenatal steroid. For the other side, there was increase on the full resuscitation when we are dealing with 22 weeks and female fibrous and the antenatal steroid given. For 23 weeks, we find most of them will resuscitate 23 weeks, regardless of the vigorous steroid given or not, with slight difference between the two groups. And in 24 weeks, which is for me surprising, not all of them will resuscitate 24 weeks. There is almost 15% of the neonatologists who are making the decision will not resuscitate 24-weeker. If I don't know why, but maybe because of the weight, they will offer different modes of resuscitation. So we ask the question of what is the main factor influencing your decision, and we ask the neonatologist, and the surprise thing was here, estimated fetal weight for the doctors is more important than the gestational age. And I think there is a difference really, which is surprising difference between the two things. I was expecting gestational age is the most important, and the recommendation is gestational age. Despite that, the consultant are looking to the fetal weight. So to conclude, do we need to revise or change our policy? I think yes, because number one, we are more than 10 years from the previous policy and recommendation. Number two, there is some conflict, which is the 16 weeks, product of 16 weeks. Some of the Islamic scholars were unhappy to be sent to the morgue, to the morgue, and they said 16, 17, and even 18 weeks should not be sent to the morgue and should be sent to the pathology, because still لا يوجد نفخ الروح أو نفخ الروح لم يتم. This is another thing which we need the Islamic scholars to be with us on this decision. Furthermore, for my personal opinion, I think still we should offer comfort care for 22 weeks, and we should individualize 23-weeker and continue resuscitating 24-weeker. We are in the process of publishing the national policy and recommendation. Hopefully, it will be published on the same paper. So these are my references, and thank you.
Thank you, Dr. Fahad, for your excellent talk and comprehensive overview. We will keep the questions at the end. We will move to the second speaker.
Bismillah ar-Rahman ar-Rahim. It's our pleasure to introduce the second speaker, Dr. Iman bin Salih al-Salami. She is a consultant in maternal and fetal medicine. She is an assistant professor at Imam Abdul Rahman al-Faisal University, and her interest in fetal medicine. Welcoming Dr. Iman. Thank you.
السلام عليكم. مساء الخيرات. ما شاء الله تبارك الله. It's a full house مع إنه بعد الظهر وبعد الغداء، فما توقعت ما شاء الله لا حول ولا قوة إلا بالله. Thank you very much for the scientific committee for inviting me, and for the organizing committee for this amazing gathering. It's always a pleasure to go somewhere and present, especially when it comes about fetal interventions. I have no conflict of interest to declare today. And I'm going to take you today with me on a journey. We're going to dive together into the fascinating world of fetal intervention, where the patient is tiny and the stakes are high, and the intervention happens before the first cry. Think of it what you do, neonatology, but with a head start. Now, these two hands holdings, it's from a case that was done in Cleveland Clinic. It was a few years ago in 2021, where an amazing team of multidisciplinary people came together, and they opened the uterus, took out a baby at a 26 weeks gestation, happened to have a pericardial tumor. They removed the tumor, put the baby back and closed. And the hand here is Dr. Hani Najim's hand, where he was leading the cardiac surgery team, and he put the intravenous cannula in the right hand for 26 weeks. It's amazing for us, but you deal with those 24, 26 weekers in hands anyway, and you do this almost every day in your specialty. But we're not here to talk about Dr. Hani Najim or a fascinating surgeries that newsworthy. We're going to actually ground ourselves in the current fetal therapy that we do every single day and examine what are the ethical dilemmas and institutional challenges that we face along that way. And also maybe have a little bit of faith in what we do and look forward to what's coming ahead from a fascinating and an amazing frontier in fetal therapy. Now, what is fetal therapy? It's any intervention that can happen to the fetus antenatally. It can be as simple as medication or supplementary diet to a complex open fetal surgery in utero. Now, why do we do this? When it comes to fetal intervention, it's actually led by one principle that evolves around it, one central principle, that the fetus is a patient whose condition evolves dynamically and throughout the pregnancy. And every or most and majority of fetal conditions, either congenital or acquired, has this critical window of reversibility. And if we intervene in that window, then we can reverse the outcome, either cardiac remodeling or pulmonary hypoplasia or whatever. And if we miss that window, then we're going to have an irreversible outcome for the fetus. Now, what we wanted to do when we treat the fetus is actually provide you with the best outcome you can manage that baby after delivery. So instead of dealing or becoming reactive to the fetus or the neonate, where we want to move into a practice with a proactive management antenatally. Now, I put this here, and I know you might not be able to read it because of the font, but it's the original article that was published in the early 1960s. And it was one of the first fetal therapies that was published in the literature, and it was done by a New Zealander obstetrician, Albert Lilly, where he did an intrauterine transfusion in 1963, and he published it. And you can see the image here that it was done under X-ray. So he injected the needle, did an X-ray, made sure it's in the peritoneal area, and transfused blood, and the baby delivered a few weeks later and didn't die. So why I share this with you here? Because it actually emphasized the point I just talked about, and it's amazing. I want you to hear this. I'm going to read it. He wrote the aim of the exercise, and he meant by the exercise is the intrauterine transfusion he did, is simply to arrest deterioration if possible. He wasn't even sure of his intervention, and gain a few extra weeks of gestation so that the skilled pediatric care of severe hemolytic disease is not nullified or stumped by gross prematurity. So that's the goal. We're trying to give you the fetus or the baby in the best condition possible. Now, since Lilly introduced the intrauterine transfusion, fetal therapy field evolved rapidly. We moved into doing open surgery and then doing laparoscopic surgeries and doing minimal invasive, until recently one of the cases was done at King Faisal Specialist Hospital and Research Center in Riyadh, where they did a fetoscopic meningomyelocele repair in Saudi. But from all that, I wanted to share with you one of the major landmark cases that was done by Michael Harrison, where he first introduced the actual fetal surgery. He saw a fetus with a major urogenital problem, And then he practiced the procedure he wanted to do on the animal and then moved it to the fetal, and he did it on a live fetus, and then the fetus survived. The idea there that he actually introduced the concept of that we can operate on that tiny patient and then get a good result and outcome eventually. Here is what fetal therapy span to or mean. It can be, as I mentioned before, non-invasive therapies, which is basically a supplement or medication, and one of the major ones here is the folic acid and B12 that we give specifically folic acid for patients to prevent open neural tube defect. And then there are some medication like a rate of rhythm control, or like digoxin or others that we can give to the mother and hopefully correct the fetal rate. Now, these medication can be given without a direct modality to introduce to the fetus, like giving it to the mom and then passes through the placenta, but it also can be introduced directly into the cord and the fetus. Now, one of the major shifts in treatment or perinatal care was the corticosteroid therapy or treatment, and you all know that. We love it, you love it. Now, Leggins and Howie, they published their landmark trial. That's every fellow in NIC or neonatology and maternal fetal medicine should read the original one. And they published it in 1970s, where shifted the management and proved that steroid or corticosteroid can actually enhance fetal lung maturity in a preterm babies. And then the studies came right after. Who can guess why I put the Cochrane Library logo here? What? Because the forest plot used by the Cochrane Library, it's actually represent the corticosteroid studies or clinical trials in the meta-analysis to prove that evidence-based medicine exists and change practice. So the logo you see for the Cochrane Library, it's a study from the perinatal medicine, or that's actually was one of the greatest studies in medicine in general. Now, in the table, I didn't mention a lot of the things, but we're gonna go some of these interventions one by one in the next few slides. One of the ones is, as I showed you, Lily did it on using an X-ray. Now we do intrauterine transfusion using direct ultrasound. So you can see here I don't know if this is, you can see here the needle comes into the cord, placental cord insertion, and then we transfuse the fetus. This is the standard of care for alloimmunization and fetal anemia. And the survival improved 90%. But this is not gonna last for long, because now there's this new clinical trial going on right now. This is the phase 2 of the clinical trial that proven that nipocalimab can actually prevent almost 50% of intrauterine transfusion in babies who are alloimmunized and women who had previous babies with anemia. Now, this is the phase 2, and we're going through phase 3 clinical trial for the Azalea, the nipocalimab trial, and Saudi is involved in this trial, and I bet after this trial is published, it's gonna be a landmark trial, it's gonna shift the management of how we treat babies or pregnancies with a history of previous history of alloimmunization and previous fetal anemia. Now, laser photocoagulation for twin-twin transfusion. We know the Eurofetus study shifted the treatment for these cases, because before, babies with twin-twin transfusion used to be treated, or pregnancies used to be treated with serial amnioreduction. This is another shift in the management or how we manage these babies by the Eurofetus trial, where proven that doing laser improves survival significantly, and now this is the standard of care. We see here the fetu procedure, where we block the trachea of the fetuses who have diaphragmatic hernia to hopefully improve the lung expansion. It's using the secretion of the alveoli lung to improve the lung maturity. And here you can see it's a minimal invasive procedure that they put the scope, go through the mouth, tongue, and then all the way down. I'm going to show you, and then you can inflate. And you can see here, this is where going is through the lips, going into the mouth. And it's narrow, but that's the tongue down at 7 o'clock. And then they go in. It's going to be better. It's going to be clear once they're in the trachea. And now they go in. And once they go in the trachea, they identify the bifurcation. They go back a little bit, and then they deploy their balloon, inflate it, and they go out. And they're going in, and you can see down the hole for the bifurcation, and that's where their balloon is coming in. Now, this trial, it's actually the one that showed movement in these babies, but it's still not widely adapted because of the challenges that we're facing in these cases. They have more than almost 50% of the cases had rupture membrane and complicated by early delivery. The shunts are simple. Theoretically, we struggle with it. And we struggle because they're complicated in a way that they need a follow-up, they get blockage, they need replacement, but they're still used in some of the severe cases, and they've proven beneficial. It's interesting how when it comes to treating open neural tube defect in utero, it was first introduced in 1997 at Vanderbilt. But it wasn't widely accepted at all until the mom's trial came out in 2011, and then it became acceptable, and it showed improve in these cases. And you can see in the first ultrasound image, maybe some of our colleagues who attend our perinatal meeting, they can read the ultrasound with us. So you can see the opening of the open neural tube defect in the upper image, and then once I go down, this is the image after the repair. You can see it's closed and it's not as open as one, and this is the same baby after delivery. And then radiofrequency ablation in some cases where in twin transfusion or complicated monochorionic, where one of them can be terminated, we use the radiofrequency ablation, or we use the occlusion and bipolar coagulation in these cases. Now, I left the last two because it comes into the ethical dilemma, when to do it, how do you do it. It's a lot of, when it comes to fetal treatment, whose health is superior, the mom or the fetus? So the Shervanak and McCall made a fetus as a patient framework. So you look at, is the fetus as a patient? So is the proposed intervention beneficial to that fetus, and the benefit outweigh the risk? And what is the autonomy of the mom? What does the mom want? Does she want the intervention? Does she not prefer the intervention? And believe me, some patients, even when the fetus is hydropic and we want to transfuse, they completely decline. And it's like, I don't want. And part of it, and we know that part of it is they're scared of the outcome. Even if we transfuse, is the baby going to be okay? Is the hydrops going to resolve? Is going to be a residual neurological deficits, for example? That's all they worry about it. So we do respect that. And then make sure that your consent is complete and informed consent is documented. So we put a framework when we discuss this with our patient. What is the natural history of the disease? Is the fetus going to die or become hydropic? Or if you intervene now, it's the same if you intervene postnatally, so we won't make a difference. So what is the natural history of the disease antenatally? And then what are the risks that carried with the procedure you're proposing or the treatment you're giving to the mom? If you're giving her digoxin or you're giving her anything, what are the risks that carries to the mom and the baby as well? And then what's the timing? When are we supposed to do it? Are we missing the window of opportunity or not? And then make sure that you involve everybody in your team, that multidisciplinary. So I always brag about this, but I'm 100% sure that it's been done everywhere. We do a monthly perinatal neonatal meeting where we discuss the cases that are expected to deliver within the next few weeks. And we present these cases with the ultrasound images, and if we did MRI, and then we individualize the care. And then we invite everybody. Everybody comes into this meeting: neonatologist, pediatric surgeon, pediatric neurosurgery, all the pediatric subspecialties that involved with fetuses, pediatric cardiology, and then we get the input from them, and genetic as well. And then fetal therapy, practical challenges. We know that a lot of referral, like in Al-Haras, for example, or in other university hospital, we don't see those patients until it's late. So we have missed that window of opportunity. And then sometime when they come, we don't have the actual, we're not prepared to see these patients for whatever challenges, that institutional challenges that we have. And then maybe we're not trained enough. For example, in our center, we do not do some of these procedures. We don't do the laparoscopic meningiomyelocele. So even في التخصصي, for example, in Riyadh, they do need certain cases to keep their privilege and then to keep their skills up to date. And then how do we follow these patients? They come from Al-Hassa, they come from Riyadh. Are they coming back for referral? How often do we need to see them? Do we provide for them care as an outpatient, proper care as an outpatient with home care delivery? All these things need to be kept in mind when we talk about a full center for fetal intervention. And then documentation and communication has to be clear with the parent and the family and in the medical record as well. I hope one day we see this where we don't stop only at the perinatal neonatal meeting, but we carry the care to be personalized for every fetus, because now we are at the era of personalized medicine for people. I'm hoping that we get to that point even for the fetus as well. Believe me, the gene therapy and CRISPR gene addition, it's not science fiction anymore. It's happening now, and there are trials going on right now as we speak on SMA and hemophilia. There is also a stem cell transplantation studies done, and it's been done on a patient for skeletal dysplasia cases. So we are living in the future right now. The future that we thought it's not coming, we're living in it. So I think it's time for Saudi now, in Saudi, to move into getting ready our institutions to have these advanced procedures. And I think we do have the capabilities to do this. Fetal therapy is advancing and advancing quickly. And we do have the human capabilities, we do have the institutional capabilities. We just need to make sure that we come all together. احنا الان we're focusing على if Riyadh is going to do, لو الرياض بيسوون الفيتال intrauterine fetal surgery, then we will support them. We will send all the cases to them. If مثلا احنا we want to do intrauterine transfusion, then we want everybody to send cases for us to build our capabilities at this time. I know some people think, maybe it's not the right way to go to centralize care for certain cases, and maybe should each center have their own مثلا care for all type of cases, intrauterine procedures for all the cases, ولا for OR for operation for all the cases. That's something that we can sit together and discuss and talk, and طبعا considering the NICU capabilities حقت كل center for sure. Because when we talk about what we can do, لازم نفكر, we have to always think about, can we deal with the complication that might arise from that intervention? If our NICU is not ready to receive a baby at 24 or 25 weeks, then I shouldn't be a cowboy or cowgirl and do procedures for those babies that she might deliver in a few days, that she maybe could have completed her pregnancy until 34. وبدل ما أعطيهم 34 with a problem, أعطيهم preemie with a problem. So I think we always have to think about these things. But at the end, it's coming, it's here. I think we should be ready for it. And thank you very much.
I would like to thank both speakers, but I have a comment or a question mainly to Dr. Fahad, and I know, Doctora, you have already experience in this as well, although your lecture is different than what Dr. Fahad spoke about. But it will be in the form of comment rather than a question. It will be in the form of comment, but I would like also your comment. Now, when you speak about the age of viability, we have been speaking about this for a really long time. Since I was trained and I didn't know what to do when I became a consultant, because is it 24, 22, is it 23, is it the weight, is it multiple things? But with time, I realized one thing, which is, I think it is the mindset of people who are attending the delivery. You have the antenatal magnesiums. There should be a mindset antenatally with the antenatal magnesium sulfate or what you showed in the Cochrane about the antenatal steroid. So there should be a comprehensive, complete team that is not only powered with equipment, but also powered with enthusiasm and the mindset to really try their best for those 22 and 23 and above. We're still suffering in some places about 27-weeker and so on. And not because of the lack of equipment. I don't think it's any more lack of equipment. I think it's a lack of mindset to really help those patients. So I'd like to hear both of your comments about this.
Thank you. This is a really nice comment. I think, as we mentioned, it is a complex thing. It is many factors, not only the, as you mentioned, the enthusiastic. It is the capacity of your team, the capacity of the readiness of the family, readiness of the government to support this patient during and after admission, to support the family during and after admission. You are going to discharge at 22 weeks or 23-weeker. Who is going to support him for the rest of his life? So this is very important factors. Plus the, of course, the transport team, the labor and delivery, the networking, the transfer on time. All these are very important factors. You cannot resuscitate a 23-weeker or decide to make the age of viability 23-weeker, and then you will have a trouble and a problem in the north and west and so on. So you have to make a decision if you are making it for national, for the whole country. And this is not an easy thing. Of course, yeah. The development, the follow-up, neonatal, I think the high-risk follow-up and developmental follow-up is very important factor. Doctora, comment?
Sure. I'm going to comment from our perspective as an obstetrician. It's nice to know that you guys agree on something عشان إحنا نعرف يعني. and it's always multiple factors. أول حاجة زي ما ذكر سعادته إنه صحيح الجستيشنال weight، بس إنه إحنا نعرف the limitation of ultrasound when estimating fetal weight. There are limitations, and we always say plus or minus 500. أنا أفهم and يمكن أكون أكثر واحدة أقدر أعطيكم accurate, and it still doesn't come close to what we estimate. So this is something that we know it's flawed. الجستيشنال age ممكن الناس كلها ماسكة فيه لأنه it's the only thing that we have, but also it can be flawed as well. إحنا مو كل المرضى يجون ب early ultrasound to confirm the gestational age. So تجيني تقول لي at 25 weeks and it end up لما يطلع لكم وتشوفون وتسوون الإكزام تقول لي دكتورة والله 22 weeks it looks like. So sometimes these are actually also not يعني البارامترز اللي we deal with, it's not accurate to start with. And not because it's anybody's fault, it's just the system that we're here. It's fragmented. Patient goes to primary health care somewhere and records are not transferred. Maybe she didn't even see anybody أصلاً. إلين ما جات عندنا. So this is the first part. The second part, I think it's important, you alluded to it. It's good if there is an institutional policy دائما deals with preterm. Clarify exactly the steps. حتى لو قالوا بس إنه for each one, an obstetrician should call a pediatrician to decide case by case. So I call him, I say, this is what I have, this is how sure I am, what do you want? Do you want to resuscitate or not? At least to give me an idea, because if he said we're not, then I'm not going to monitor that baby. It reflects on us as well. I'm not going to give that baby steroid for fetal lung maturity. I'm not going to give that baby magnesium sulfate. I'm not going to do all these things. And also it has to have something in the policy says everybody comes in after 24 weeks to give them steroid for fetal immaturity, to give them magnesium sulfate for neuroprotection, to be clear that if a resident is there or a trainee or a specialist, they don't have to guess it's there. So it's multiple things, but also I always say, إن كل NICU غير، كل NICU عندهم السرفايفل ريت حقهم، وNICU عندها 5 أسرة غير عن ICU عندها 40 سرير، always individualize.
ثانك يو باشا. بروف صاعدي تفضل.
These important issues regarding the importance of the presence of institutional policy. I think that's very important. I remember in our hospital in King Faisal Specialist Hospital, Jeddah, at one point among us as a neonatologist, that 24 weeks gestation we restate, or 500 grams. So one day, twins did, according to the gestational age, 23 weeks. One of them 500, the other one 420. So the neonatologist on call decided to restate both. Another neonatologist who received from him the other day said, why you restate? We didn't agree to restate 400, particularly that the gestational age 23. Then we changed the policy and we said 23 to less than 24, the combined decision of the consultant neonatologist and the consultant obstetrician. After 24 weeks, we restate. Besides that, the importance of presence of institutional policy or guidelines, I think from medical legal side of view, is very important. I think I urge that every institution should have internal, we'll say guidelines or regarding this, because medical legal, I think, very important. Regarding just a comment, Dr. Fahd, regarding unit doing neonatal surgery in the NICU, I think since 2001, we'll do it in King Faisal Specialist Hospital, Jeddah. A matter of fact, BDA ligation, sometimes we'll do it in the NICU if the OR is busy. As well as sometimes the patient goes for BDA ligation. Open heart surgery will go to CSICU, but once they close the chest, it comes down to the NICU. Thank you.
Thank you very much. I need to do a comment. Thank you. Yes, Dr. Jubara, please.
Thank you very much for both speaker for a fabulous presentation. Again, my question regarding the limit of viability. We know all these guidelines and even like the scholarity opinion, it was more than 10, 11 years ago. So it's, you know, medicine and neonatology has been really changes. Like 10 years ago, the survival and morbidity of 27-weeker was different than from now. Facility improving, training has been significant improvement in training, equipment, everything is really available. We heard this morning about MIST, LISA, you know. So I think we need to have an updated recommendation from all aspects, medical and non-medical, you know, for this limit of viability. I do agree, at this stage, it's not comfortable to leave 23-weeker, especially in the higher centers where even the follow-up, you know, is there. So if I put, for example, general guidelines, 23-weeker, not to restate below 23-weeker, so it will be very difficult to really apply it. Our kingdom is variable. You have a level 4 in ICU, and you have very limited level 1 in ICU in the brewery. So I think this point should be taken in consideration. The other thing is the mindset, as what Dr. Salam mentioned. I think we need to work on that from both obstetric and neonatology. So having guidelines, having like a meeting for or call and decision before the delivery of each these cases. You know, we don't resuscitate 22-weeker, but they admit the patient to us. They did not call us, and when she was 23, because our local guidelines is 23, she did not receive steroids. You know. So it's really very complex, but we need to have a decision from all aspects, including religion, you know, scholarity, because this, like the definition, it's more than really 11 years, and we're still following that. Last thing is the medico-legal aspect. I received several calls in life-saving. They resuscitate 22-weeker in the peripheral hospital, and they call me for transport. So I asked the doctor why. He said because they will complain. The parent will complain. Again, putting a lot of you know, hazard on the physicians, on the transport team. You cannot leave a living child 24 hours because of 22 weeks. Leave him in that periphery. So you need to transport, you need to send him to other tertiary ICU. So I think the medico-legal aspect also in resuscitation of limit of viability need to be addressed and in urgent really matter. Thank you.
Thank you, Dr. You need to do.
Okay, just a short comment. You mentioned a lot of things. I cannot comment in, but medico-legal, we put the clearly, and this is hopefully solved in 2014 when we put the definition. There was no definitions in Saudi Arabia. Since 2014, there is a clear definition. So you can use these definitions, which was approved by Ministry of Health in the court. For the resuscitating of 22 weeks, nobody will ask you in the court why you are not resuscitating. So there is a clear definition from Ministry of Health, and nobody will say anything, supposed to be, because this is a policy, the national policy. A lot of discussion about this, but I will not go through it. Now, do we need to change? Yes, we need to change, but I will tell you a secret. I was communicating with the BABM actually last 2 or 3 months when they are updating their policy. I have a comment on it and I send it to them. And the main reason they will update it is because they are resuscitating every 22 weeks and they are not happy. They want to individualize and reduce. So we are not going more resuscitation, we are reducing the, so this is why they put it in categories and leveling, so the people support the decision when they are deciding in the middle of the night, this is high risk, don't resuscitate, just give comfort care. So yes, we are in 2025, but I think till today, we should not, we should think really of whom we can resuscitate and whom we should just give a comfort care.
Thank you, Dr. Fahad and Dr. Iman, for the excellent talk. And we will move to the third speaker. She is waiting for us to start. Dr. Michelle Barton-Varbs, an associate professor and division chief of infectious diseases at the Children's Hospital London Health Sciences Centre in Canada. Dr. Barton completed her postgraduate training in pediatrics at the University of the West Indies, Jamaica, followed by clinical and research fellowship in pediatric and transplant infectious diseases at the Hospital for Sick Children at Toronto. She will be sharing her talk about universal congenital CMV screening. And welcome, Dr. Michelle.
Thank you for having me. I was asked to give a talk on congenital CMV, and so I will be talking about CMV as it relates to the various changes that have taken place recently, in particular around treatment and the emerging data that suggests preventive strategies can be applied in the antenatal period. So today I hope to summarize the epidemiology and seroprevalence and quickly review the symptoms and signs, and then and the diagnostics, and then quickly go into the changes in management. So congenital CMV is very important because it is the leading cause of non-genetic hearing loss, sensory neural hearing loss, and it is the most common congenital infection that we see. It accounts for roughly 0.67% of live births in North America and Europe, but in developing countries, it can reach to as high as 6%. In Canada, our rates run less than 0.6% since we've started our population-based screening in Ontario. Our numbers are much lower than that, than the 0.6%. In terms of the epidemiology, you know that this is a virus, it's a beta herpes virus that basically has lifelong latency in humans. And in fact, it is very common for an adult reproductive woman to be already positive. So ironically, even though primary infection in the mother is highly associated with the likelihood of getting fetal transmission and congenital infection, the patients who have non-primary disease that is acquiring it probably in childhood or in their teenage years, when they get into pregnancy, they have a lower risk. But cumulatively across the world, most of our babies who have congenital CMV will have it from reactivation of non-primary disease in their mother. We'll go over that a little bit more. I know it sounds a little confusing, but I'll mention it a little bit more. So this just shows the global distribution in terms of seroprevalence with countries, as you can see, like Asia, having high seroprevalence greater than 90%. So the developing world tends to have higher seroprevalence. And the rest. So why is congenital CMV important? This is the point I want to highlight. The main reason, even though we talk about the small 10% that have significant neurodevelopmental delay, what is most concerning is that this is an important cause of sensory neural hearing loss. And in the first circles, the first circle, you see the contribution of CMV at birth to hearing loss, and it accounts for 1/5 of babies with hearing loss will have CMV. And then you see genetic causes are quite important. But the important thing about CMV is that even if the babies get off the hook at birth, they still have a risk of developing late onset hearing loss. And you see in the bigger circle to the right that when they looked at children 4 years and older, looked at children 4 years old, they saw that CMV was accounting for still a significant amount of hearing loss. So there is progressive hearing loss, and you see the breakdown that whereas in the newborn, 10% of that hearing loss is clinically apparent. In the 4-year-old child, you see that it's kind of split between the clinically apparent infection being only 7%, and then the clinically inapparent 8%, and then 10%. So you end up getting an additional 10% over the 4-year period that develop late onset hearing loss. So among newborns, you will see that 7%. So this is asymptomatic newborns. So you will see that sensory neural hearing loss is present in 7% of babies by 3 months. And then by 5 years, it's 14%. And by 18 years, it's 25%. So it's a progressive increase. And then, so the hearing changes that you see, what we do know is that the hearing loss that comes on later is not as profound as the one as the subset that we see in the neonatal period. And then hearing changes can be asymmetrical. And in the progressive hearing loss, this is isolated hearing loss, as opposed to in the newborn period, we can get hearing loss along with the other constellation of the congenital syndrome. So overall, what we are looking at is 40 to 44% of symptomatic congenital CMV, babies with congenital CMV will develop sensory neural hearing loss. And so, whereas amongst the asymptomatic group, we're talking about roughly 10%, 11%. So it's important even in the asymptomatic. And this is how you counsel your patients, even if they look good at birth and there's nothing to find on the investigation, you still have to prepare them that 10% of their babies will end up with hearing loss. And that's why you need to continue to follow them beyond the neonatal period. And then the other important aspect that we all know is the neurodevelopmental sequelae. So the neurodevelopmental sequelae, we're looking at in the 10% that are symptomatic, 90% of them will end up with neurodevelopmental. So whereas neurodevelopmental delay is rare in asymptomatic babies, is 5 to 15%, although this data is evolving because this data predated us doing universal screening. Now that we're doing universal screening, we're picking up all the babies, and now we've progressed to doing more MRIs. We're seeing that even babies that we thought were asymptomatic and didn't have even had normal ultrasounds end up still having white matter changes on the MR. So this basically shows that this is a nice figure that compares the first trimester, if congenital CMV occurred in the first trimester versus later, the impact. And we know that obviously the babies who acquire the infection in the first trimester are at a highest risk of all the consequences. And then this basically shows a survival curve for babies over time who acquire the infection either because of a mother with secondary non-primary infection that reactivated versus primary infection. So how is CMV transmitted? So we know there's horizontal and vertical transmission, and basically, horizontal and vertical transmission. And the horizontal transmission, takes place, even though we say blood transfusion, and that's probably that we screen our blood, so that's not as the more important thing is the intimate contact with infected body fluid and sexual intimacy. The intimate contact is probably the most important point to highlight as it relates to mothers and their exposures, mothers who work in daycare or mothers who have many young children. They are prone to getting primary infection if they don't have it, or to get new strains of infection. So even if you don't have primary infection, if you had infection from in your childhood, because you have different strains of CMV, you can get a new strain upon your old strain, which makes your risk a little bit more than just the non-primary infection. The CMV vertical transmission can take place in utero or around the time of birth or postnatally through breast milk. we're not so worried about postnatal, although new data emerging is showing that the postnatal infections, particularly in the preterm babies, can be quite challenging in the newborn, in the neonatal unit, with significant transaminitis, pneumonitis, and even neck. Okay, so primary infection, when we talk about the maternal infection, we want to establish that it's either primary or non-primary. Non-primary means they had it earlier in life and it's just reactivating in the pregnancy. So what are the risk factors for maternal CMV? So mothers who have multiple partners or mothers who interact with young children are probably the highest risk. Recognizing this, then it is important to note that we can prevent. There are some preventive strategies that we can apply, and it's important to educate our mothers to avoid or reduce exposure during pregnancy to children who are shedding. But there's new data coming out in terms of secondary prevention. Even if the mother ends up getting primary infection in utero or in the periconceptual period, there is role emerging data that suggests there's role. We'll look at that. So the preventive strategies I mentioned to reduce, avoid new partners and be careful with hand hygiene and don't share utensils with young babies. So this trial basically established the role of, this is the vaccine, emerging vaccine trials are going on. No vaccine candidate has been approved yet, but they're in various phases of trial and promising. In terms of the trial that established the role of antiviral in mothers with primary infection in the first trimester, this trial published in 2020 showed that valacyclovir was effective in reducing the rate of fetal transmission if it was given early in pregnancy and continued through until amniocentesis. And this is a meta-analysis that combines 3 trials, and it came to the conclusion with a total of about 500 study participants. It came to a conclusion that 8 grams per day of valacyclovir reduced the vertical transmission rate in these mothers with early trimester infection. So there are consensus guidelines that have recently been published for the UK, for Europe, which basically emphasize the use of these strategies in mothers. Okay, so when should we suspect congenital CMV? Obviously, there are antenatal clues, and in the European guidelines, they now recommend routinely testing mothers in their first trimester, early in their first trimester, for CMV, IgG and IgM. In Canada, we are still we're not doing preemptive testing. We are testing in response to findings in the antenatal period. That is, suggestive fetal ultrasound findings. Bowel thickening is probably one of the common reasons why we'd screen a mom for torch infections, and all things being equal, congenital CMV would be high on the list. But these are other causes to screen. And then, of course, everyone knows that obviously if you have a baby born with a constellation of symptoms that is suspicious for congenital CMV, then we would also screen those babies, or if a baby has isolated hearing loss. So those are the reasons to think about it. The findings for CMV are well described. I'm not talking to folks that don't know, so I'm just going to skip quickly over this. But it affects multiple systems, and it basically can mimic sepsis, but it mimics other congenital infections. This table basically summarizes the clinical findings but highlights the abnormal lab findings. I would highlight significantly the thrombocytopenia. Thrombocytopenia is an important marker, and we strongly advocate that in the NICU, even though there are many causes for thrombocytopenia in NICU, when you have a baby with persistent thrombocytopenia, certainly a baby who, we used to say, when we have a baby with persistent thrombocytopenia, one who's requiring frequent transfusions, you should ensure that you have done the CMV screening on the baby, urine CMV on that baby. However, we've started to do it even on just any baby who has thrombocytopenia at birth, and we have been surprised to see how many more we are finding. Okay, I'm just going to quickly, or maybe in the interest of time, I won't I'll just quickly highlight this because it was an interesting case that we had. Infant born at 26 weeks, and transferred to our institution at day 2 as a sepsis with on AMP and GENT. Sorry? Oh, I thought I heard somebody saying something. The baby was symmetrically small and had respiratory distress. You know the platelet count is low at 50, and you know there's transaminitis, both AST and ALT, and the Bailey is 90, and it's mainly direct. So the direct hyperbilirubinemia is definitely a clue. Along with the thrombocytopenia. And LP is done, and the baby is noted to have 21 white cells. Acyclovir is added, thinking, common things being common. However, on day 4, there's worsening respiratory status and falling platelet counts to 25. And the transaminitis is slightly worsening. And the chest x-ray shows bilateral infiltrates. Basically at this point, the team had not really started to think about torch infections, but they really should have. However, fortunately for them, they got a call from the pathologist who informed them that the placental findings were suggestive of maternal CMV. And so based on that, they sent off confirmatory testing and started empiric antiviral. Question though, which antiviral would you have started in a 26-weeker who is in respiratory distress? Well, for sure, ganciclovir, because we need some IV therapy here. So even though Valgan is the treatment that we will use routinely in congenital CMV, the indication for IV therapy would be any baby who is not able to take oral or who is extremely sick. And this is an extremely sick baby, preterm, who needed IV therapy initially. Eventually was transitioned to oral. And so all right, I'm just going to skip over that. The take-home point from that case was that congenital CMV rarely presents as an overwhelming sepsis picture, but in this case, the baby looked quite septic, and what was really contributing to the respiratory distress was pneumonitis. So severe thrombocytopenia requiring multiple transfusions should trigger the thoughts about CMV. As well, we've had really bad necrotizing enterocolitis, and sometimes you can get a pancolitis with perf. That you should, in patients who have like significant pancolitis and they're thrombocytopenic and stuff, and think about doing a urine CMV on those babies. So what diagnostic test should you do? Well, urine CMV, of course, and it must be done early. And that's why we say as soon as you start seeing thrombocytopenia, just do it, because by the time you wait until after 21 days, it becomes a blurred picture. You don't know if it's postnatal or if it's congenital. the other testing that is available is saliva. The saliva CMV PCR performs very well, as does the urine CMV, and is less invasive. However, the challenge is that it basically, you can get false positives if you don't wait at least an hour after breastfeeding. So we, in our population-based screening in Ontario, started off with urine CMV, and then we added saliva screening to optimize our pickup, because the dry blood spot test, which we use for screening, we started off using that for screening, has a low sensitivity, as you can see. We have a high performance one that can take us to almost 80%, but still, we wanted to be able to get to the 95% that we can get from the saliva. So by adding the saliva to the urine, we were able to increase our detection rate. So blood PCR is not routinely recommended for diagnostic purposes, simply because, again, with congenital CMV, most of our babies have it early in the trimester, in the first trimester. By the time they are born, they're not having regularly circulating CMV in the blood, because it's now deposited in the sites, whether it is in the brain, in the liver, and then you have spillovers. So when you take the blood, you may miss the period of time, unless, of course, the baby is overwhelmingly septic, has pneumonitis, like that baby that I described had an extremely high blood level. So the blood level has its role in the very sick babies, the babies who have significant organ dysfunction. Then they may have elevated blood levels, which may help you to watch, to monitor response to treatment. Spinal fluid is not routinely recommended, but if you are doing an LP for another reason in a baby who has CMV, send some for CMV. And then, okay, so brain imaging. So what we have done in Canada is that we would normally, any baby who has congenital CMV would get, symptomatic or asymptomatic, would get a head ultrasound. That's how we started off when we started our population-based screening in 2019. And we would only proceed to an MRI if the ultrasound was normal. However, data changed over time, because, as you know, it's very common to see subependymal cysts in even healthy babies, but that happens also in CMV. And so we started realizing that, and as the literature progressed, even in this study, it basically showed that abnormalities occurring up to 30% of clinically asymptomatic babies. So this study was advocating MRIs in all patients. What we do is we used to apply MRI only to the babies who had specific CMV findings, and we would leave out the babies with the tiny subependymal cysts. But now we say any baby who has microcephaly, relative microcephaly, any baby who has any changes, any abnormality on the ultrasound moves on. But I believe that we actually may move to this, where we don't have a consensus yet that we're doing it in all babies, because it is not necessarily easy in all places in Canada to get an MRI on the babies. So we say all babies with any abnormality in ultrasound, but this study is actually recommending that it be done on all babies, regardless of whether the ultrasound is normal or abnormal. And this imaging highlights the changes that we can see. Obviously, in A, nobody would miss that, because there's extensive polymicrogyra in that one. And then, of course, in the middle one, the cysts that you see, we can see that, but the ventricular dilatation as well as the adhesions are can also be supportive of CMV. All right. So once you have your diagnosis, you need to classify your patients as asymptomatic. I'm getting a lot of feedback. Hello? Am I supposed to stop?
Yes, Dr. Michelle, you can continue.
Oh, there's so much feedback in the background. Maybe somebody needs to be muted. I don't know. Anyway, the classification. So we classify based on what is found, whether there is isolated sensory neural hearing loss or other findings. So this is a Red Book's classification. And the classification helps you to guide you as to who needs treatment. And so the treatment changes were recently made with a new Red Book. And we are still revising. We are now in the revision phase of the next Red Book, which will come out in 2027. However, this is the current recommendation that any baby who has, everybody knows the last box, any baby who has central nervous system involvement should be offered 6 months of valganciclovir. But also babies with single severe organ dysfunction, so let's say only thrombocytopenia but multiple transfusions they would need, or babies who don't necessarily have one single organ but have multiple organs, not necessarily severe but combined together it's impacting, then those babies also may be considered for treatment. But what is new is that we've now agreed that isolated hearing loss, babies who are asymptomatic otherwise and just have isolated hearing loss, those babies should be offered 6 weeks is what we recommend, what the Red Book recommended, 6 weeks of valganciclovir. This is very controversial because the data is still evolving. And in fact, in Canada, many of us as experts still offer those isolated babies with isolated hearing loss, 6 months instead of 6 weeks. So we tell the parents 6 weeks is what Red Book recommended based on the limited data that was available, because they really did not follow these babies and they did not do a neck and neck challenge 6 months versus 6 weeks. And so we feel that if the rationale for giving 6 months was to best maximize the baby's brain development over that 6-month period and keep the virus asleep. Data is now so in the babies who have isolated hearing loss, you know, there are some people who were not doing MRIs on these babies because the head ultrasound was normal. We now do a head ultrasound, an MRI on these babies, and there's no findings that are suggesting that some of these babies with isolated hearing loss may actually have white matter changes. So if you're in a center that you did an ultrasound, it was normal, the baby subsequently developed isolated hearing loss, and you ended up offering 6 weeks, you would not have dealt with you would not have optimized the baby's care management if there was white matter disease. So yeah, some of us actually offer 6 months, but the recommended Red Book is 6 weeks, and we tell the parents that and then give them the options. And then obviously if the babies are asymptomatic completely, they don't get any treatment. And then so we all babies who are symptomatic should be referred to an infectious disease specialist for evaluation and follow-up. And then we then apply the treatment as I showed you in the previous slide. And the treatment is valganciclovir that we are going to start. We used to say start within a month, but now with the new recommendations, we have a little bit more time, up to 13 weeks. But even though you have up to 13 weeks, we say the earlier you start, the better the outcome. And so valganciclovir is given for 6 months. IV ganciclovir can be given in the babies who are very sick, and then transition once they can tolerate oral. In terms of the follow-up, these babies need to be seen regularly because of the adverse effects associated with Valgan or ganciclovir. It's known to predominantly, the main one that we see is likely to happen in the first month to 2 months, and that's why we follow them so closely in the first month to 2 months, where we see them weekly. We look for leukopenia, so it can be any cytopenia, but mainly leukopenia, meaning neutropenia, is the most common side effect that we see. You can also get transaminitis. That tends to come on a little later, around about 4 months into treatment. And then you should also monitor the urea and creatinine. In terms of other follow-up, they need, even if they were normal, had normal audiology at birth, they still need regular audiology. And depending on what is feasible in your country, so the Red Book recommends 4, 6, 9, 12. In Canada, we don't do that. We have limited, so we do it Q6 months. For the first 2 to 3 years. But in the Red Book, they recommend that frequency that you see in the second bullet, 4, 6, 9, 12, and at 30 months. And then, yes, and as well, the baby should be followed for ophthalmology. We have found, so we were doing, in our universal screening cohort, we were doing ophthalmology assessment on all positive babies. And then we just evaluated our 5-year experience, and we noted that we had no eye abnormalities in babies who were asymptomatic. And based on that, we have stopped offering ophthalmology assessment to babies who are asymptomatic and just focus on the babies who are symptomatic. Symptomatic, including if they develop isolated hearing loss, they should get eye exam. So this is controversial, and it will depend on which country. I just give you our country's spin. Neurodevelopmental evaluations should be done, and these patients should be followed. What is actually and will come out in the next version of the Red Book is the focus now on cerebellar function and vertigo that may occur in otherwise okay babies. And so that aspect is evolving, and you should see more studies coming out on that. So in conclusion, congenital CMV is the most common congenital infection, and it is an important contributor to sensory neural hearing loss. It is an important cause of neurodevelopmental delay in symptomatic babies. New preventive strategies are now being pushed for the pregnant mother, and there's an opportunity to offer secondary prevention through valacyclovir therapy in first trimester until amniocentesis is done. And babies who have suspicious antenatal concerns or constellation of symptoms should have screening if your country is not already doing universal screening. Universal screening is becoming the way to go if you can establish it, and should be done using the dried blood spot plus saliva if you can afford it. Saliva would be best if on its own if you can afford it, but just recognize that there may be a high false positive rate. and yes, there are new guidelines. MRI head imaging is being done more often, as well as there is an increase in offering of treatment to babies, not just neurologically abnormal, but other system dysfunction or isolated hearing loss. And the length of treatment is still considered controversial for the isolated hearing loss, but for the rest of the babies, it's 6 months. That's it for me. And if you have any questions.
Thank you, Dr. Michelle, for your comprehensive overview about congenital CMV. Any question from the attendees or audience? Okay, thank you, Dr. Michelle. That's
You're
it.
welcome. Thank you. All right.
Thank you.
Thank you, everyone. Thank you for the moderators and thank you for the speakers. I think now for the first day, we've concluded the scientific program, the didactic at least. Now we're moving to the ventilation today. Just to remind you of the workshops that we have in this conference. So the first day, we're going to have a ventilation workshop. It's a hands-on workshop. We should be starting shortly. It will be in the Topaz room. It is on the lower floor from here. They will start within 15 minutes. And tomorrow we have a hands-on vascular access workshop, mostly ultrasound guided. We'll be talking about central, peripheral, and midline insertion with hands-on experience as well. Thank you very much for attending and hope to see you tomorrow and hope to see the people that registered in the conference, in the workshop, I mean. Thank you very much.